right, so since we don't have a cactus in this room, we'll go ahead and get started. Welcome back from lunch. We're ready to launch into the last of our 12 scientific sessions. Just a reminder, there are 3 concurrent scientific sessions running this afternoon. In the main room are the abstracts on global surgery and health disparities. In this room, there are the colorectal scientific abstract session, and then in Grand Saguaro West, there is the education abstract session. So if you wanted either of those, please make your way there as quickly as possible. I'm Dr. Christine Velasco. I'm the Director of Colorectal Surgery at Arnold Palmer Hospital for Children in Orlando, Florida, and I am joined by my co-moderator, Dr. Irene Limbutel, who is Associate Director of the Comprehensive Colorectal Center at Children's Mercy, Kansas City. We'll get started.
So first up, we're going to call Dr. Nepomuceno from Stanford University.
Hello. I'm one of the postdoc research fellows from Stanford. We have no disclosures. We did this research because emerging evidence shows that 2- and 3-stage procedures for ulcerative colitis are comparable even in patients who were considered high risk for complications. Current literature continues to provide limited guidance. Children with medically refractory ulcerative colitis typically undergo total colectomy with pouch creation. The current belief is that a 3-stage approach may be preferable in patients with ulcerative colitis who are clinically unstable or high risk for complications, with the pretext that the restorative pouch can be performed after patient optimization. However, there is still limited evidence to support this trend. This slide outlines the two approaches. Here, we define 3-stage as colectomy with stoma formation, followed by pouch creation, and then subsequent stoma reversal. And then a 2-stage approach would be concomitant colectomy with pouch creation, and then stoma reversal. Factors guiding the 3-stage approach include improved patient status at the time of pouch creation, but also involve the added cost and morbidity associated with an additional procedure. The 2-stage approach risks anastomosis in a potentially sicker patient. We aim to compare the 30-day outcomes after pouch creation for patients undergoing 2- and 3-stage procedures using the NSQIP pediatric database. We queried NSQIP-P for children under 18 years old with ulcerative colitis from 2016 through 2022. And then we use CPT codes to categorize patients into 2 groups based on whether they had concomitant colectomy and pouch creation, which would be a 2-stage approach, or pouch creation alone, which would be a 3-stage approach. These are the 2 different groups and the time periods of the treatment points and the outcomes that we examined. With this approach, there is an expected difference in the baseline physiologic status. And to account for this difference, we use propensity score matching, looking at a priori selected covariates, BMI, steroid and immunosuppression use, and ASA class. We then used logistic regression to examine rates of adverse outcomes among the 2 matched groups. Adverse outcomes were included as any one of mortality, organ space infection, progressive renal insufficiency, systemic sepsis, or intra-abdominal reoperation. These were the baseline characteristics for our patient population. Significant differences can be seen in steroid immunosuppression use and preoperative nutrition status as seen in albumin. There was a small but statistically significant difference in surgical approach, but because it is difficult to account for factors leading to surgical approach, ASA was considered to be a better variable. Importantly, albumin could not be included in propensity score matching as more than 50% of data was missing from NSQIP. So patients from each group were matched 1-to-1 based on BMI, ASA class, and immunosuppression or steroid use, with 322 patients included in the study. After propensity score matching, we can see that BMI and age are well matched across the 2 groups. And then after matching, statistical analysis generates this odds ratio, which represents a 1.6 times greater likelihood of adverse outcomes for the 3-stage group, but this confidence interval shown here is not statistically significant. In summary, there is no significant difference in outcomes after pouch creation in 2 or 3-stage colectomies after matching for BMI immunosuppression use in ASA class. One limitation of NSQIP is that it does not compare serial procedures. Thus, morbidity and complications that occurred prior to pouch creation for the 3-stage group were not captured in this study. Thus, future directions should include longitudinal studies that can follow patients from their primary to final surgeries. Thank you all for your time and attention.
Jason Fisher, Cincinnati. Great presentation and really a question that we don't have answered in pediatrics. Maybe I missed it. I've changed my practice in the last 5-7 years of what a 2-stage procedure means, meaning that the adult literature strongly suggests now that we do a subtotal or abdominal colectomy and ileostomy first and make your pouch after the patient has been off biologics, and then plus or minus an ileostomy, which make it a 2 or a 3-stage procedure. Can you decipher from your data, did they get the old 2-stage procedure versus the new 2-stage procedure? And are you able to decipher did that change the outcomes in our population? Thanks.
Thank you for that question. So yes, the definition of the 2-stage procedure is important for what we're comparing here. And I think the question we're really asking is, can you do the pouch creation and colectomy at the same time? When looking at NSQIP, the CPT codes we used included with or without diverting ostomy. So no, we couldn't really decipher which kind of 2-stage approach those patients were undergoing. But the question of whether they were able to get the pouch creation separately or at the same time as the proctectomy, or as the colectomy, that was captured in this study.
Great presentation. I'm Hira Ahmad from CHOC. I'll take it a step further. Some of the adult literature even suggests single stage without a protective ostomy, just creating the pouch. And I was just curious if you came across any of that data in your query. And then my second question is, were you able to decipher how long prior to surgical intervention were the biologics stopped? Like if there was a timing of 4 weeks versus 8 weeks or 12 weeks, and if you were able to tell that in 2 different groups. Thanks.
So we weren't able to capture that in this for your second question as far as how long biologics were stopped prior to the surgery, only whether or not they were on them at the time of the procedure. As far as the question for the 1-stage approach, we didn't look at that specifically in this study.
One other question from us. In your data, were you able to parse out what types of biologics they received? Because obviously older biologics in the past were limited to just 1 or 2, whereas now there's a whole handful of them. Is there a way to do a sub-analysis with those different biologics?
I know we were able to determine, whether or not they were on steroids or the biologics, but I don't think we were able to determine which biologics they were on specifically.
Thank you.
Thank you.
Next, we have Dr. Monemi, I apologize if I mispronounced your name, from the University of Virginia.
You did great on the pronunciation. Yeah. Thank you for the opportunity to present our work here today. We have no financial disclosures. So Hirschsprung disease affects about 1 in 5,000 live births, resulting in distal aganglionosis and proximal colonic distension. And after pull-through surgery, about half of these patients continue to experience ongoing bowel dysfunction. So we hypothesize that chronic distension plays a critical role in this dysfunction after surgery. So the enteric nervous system, or ENS, is derived from a migratory neural crest cell population, and our lab has chosen to focus on a mutation in the endothelin receptor B gene, which faithfully replicates the Hirschsprung phenotype with a ganglionic, aganglionic, and transition zone segments as seen here. Our lab has previously shown altered collagen deposition in equivalent colonic segments in our knockout mice when compared to wild-type littermates using the mouse model. And on histology, we noted a variability in the location of collagen deposition with increased deposition in the submucosa when compared to wild-type. So our study had three main aims. First, to evaluate if collagen deposition in Hirschsprung patients is also increased, similar to our mouse. Second, to evaluate the physical properties of the proximal bowel of Hirschsprung mice compared to wild-type littermates. And then third, to assess if there's a dysregulation in the expression of fibrosis-related genes in the ganglionic colon of the proximal bowel of Hirschsprung mice compared to their wild-type littermates. So to study our first aim, we had two different groups. In our first group, we used equivalent human intestinal samples of patients with Hirschsprung disease that are age-matched to controls, and the samples were fixed and stained using Gamori's trichrome staining, which stains collagen blue. The samples were then analyzed in image J and to compare the collagen content across the submucosa and muscularis propria. And in our second group, we aimed to assess if distension alone was a factor. So we used equivalent proximal and distal intestinal segments from intestinal atresia patients to assess collagen deposition using the same protocol as in our first group. These studies focus mainly on the muscularis propria and submucosa because those are where the majority of the intrinsic ENS reside, as shown here in green. We found that the Hirschsprung samples in panels C and D had increased collagen deposition when compared to the controls in panels A and B, replicating the same results that we found in our mouse model. We then did the same for the samples in our atresia patients using the distal non-dialytic segment as a control for each patient, and we found no difference in collagen deposition as well as the normal distribution of collagen in the submucosa, mucosa, and muscularis propria. To investigate our second aim, we took equivalent colonic segments that were isolated for adult EDNRB mice and their wild-type littermates and used atomic force microscopy to quantify the Young's modulus of the muscularis propria and determine if there was any differences in stiffness. And for our third aim, we isolated RNA from equivalent intestinal samples of Hirschsprung mice and controls and queried gene expression using a profiler PCR array of fibrosis-related genes. So we found that on average, stiffness in our Hirschsprung proximal colon was about 22 kilopascals when compared to 15 kilopascals in their wild-type littermates, which was approximately 1.4 times stiffer and significant when you accounted for the variability by normalizing to control. And when we look at the differential gene expression, there was dysregulation of 14 or 4 fibrosis-related genes and of 19 inflammation-related genes. And the genes that reached the level of significance were with increased expression of tissue inhibitors of metalloproteinase 1, lysyl oxidase, integrin B1, and interleukin 13 RA2, which are all known to be profibrotic in other organs. So with our findings, we plan to look at the phenotypic differences and function of neurospheres grown in substrates of varying stiffness to hopefully replicate what we saw in our mice. Second, to evaluate the complete extracellular matrix protein profile of our Hirschsprung's proximal colon compared to their wild-type littermates using bulk RNA-seq. And then third, to determine if a postnatal mouse model of distension has the same differences in collagen deposition as we saw in the humans and our knockout mouse. So in conclusion, our findings in conjunction with our prior work suggest the proximal ganglionic bowel in Hirschsprung is stiffer, more fibrotic, and possibly is a contributor to the continued bowel dysfunction experienced by these patients even after surgery. Thank you, and I'm happy to take any questions. Hey.
Hey, Andrew Zigman, Portland, Oregon. Great stuff. Loved it. So thinking 17 steps ahead to human mice with Hirschsprungs. Just in your observations, did you get a sense of how far north of the transition zone you saw increased fibrosis and collagen deposition?
Yeah, so, oh, is this on still? Okay. Yeah, so we also did these experiments in the distal ileum, so we do know at least it goes that far. There is the possibility to do it for other segments because when we're harvesting, we can harvest the whole bowel and do it. So that's a great thought for the future. Yeah.
Like back of the pharynx.
Correct, correct,
That
correct.
has an implication of how far above the transition zone we resect.
Exactly.
And keep up that work.
Thank you.
Can you hear me? Do you have any ways to just study if the degree of fibrosis can change over time? Because as somebody who's interested in late diagnosis Hirschsprung's, I think that's going to have some clinical implications as well.
Yeah, so that's a great question. Thank you. We have had those thoughts. The unfortunate part of using an EDNRB knockout mouse model is that they die at about wean, which is about 21 days or 3 weeks. So we are looking at other ways to prolong their longevity, and a group at CHOP, an ENS group at CHOP, uses a lab diet that they can get the mice out several weeks. So we've now switched to that diet. And also, yeah, that's really about what we can do right now. So if that's successful, then we can look at that at least for a couple weeks when they reach maturity.
Thank you.
Cool. Thank you.
Next up, we have Dr. Johnson from CHOP presenting.
Thank you for the opportunity to present here today. We have no relevant disclosures. So ileocecectomy for pediatric Crohn's disease is, of course, a relatively common operation that we perform. However, why some of these patients recur after their initial surgery and others do not is somewhat unclear. The prior studies that have looked at this topic are somewhat limited by relatively small sample sizes and are dependent on a lot of patients that are drawn from the pre-biologic era. To further understand this question, we sought to investigate our relatively large institutional database with a patient population drawn entirely from the biologic era. So as for our study design, we looked at our institutional database over a 10-year period of patients aged 1 to 21 who underwent primary ileocecectomy at our institution and were subsequently followed for at least 6 months. We then looked at recurrence patterns, the reasons for why these patients recurred, and ultimately how they were managed. For purposes of this study, we used clinical guidelines that were previously published that defined endoscopic recurrence simply as any endoscopic evidence of disease activity in the ileocecal region, and clinical recurrence as the reappearance of symptoms associated with any objective signs of active disease. So with that criteria, we ultimately identified over 200 patients eligible for our study. The median follow-up was over 2.5 years. The average age at surgery was about 16, and the vast majority of patients underwent laparoscopy for their initial surgery. Unsurprisingly, there was a substantial proportion of patients who were treated with biologic medications preoperatively, and a large proportion that also at some point were transitioned to a second-line biologic. There were smaller subsets of patients that also underwent examination under anesthesia for perianal disease, either during or before their ileocecectomy, and another group that underwent an additional intestinal resection outside of the ileocecal region. As for the ones who actually recurred, we had about a third of patients who demonstrated endoscopic recurrence overall, about 2/3 of which occurred directly at the prior anastomosis. Naturally, the longer patients were followed, the rates of recurrence subsequently increased. As for the actual risk factors that increased the odds of recurrence, well, those were relatively limited. We found that those that required an examination under anesthesia for perianal disease and those that required transition to a second-line biologic medication were more likely to recur. All other risk factors that we looked at that had been variably implicated previously in the literature, such as age, biologic sex, disease phenotype, whether it was stenosing, inflammatory, or penetrating, and also disease activity at the pathologic surgical margin, didn't have any effect on recurrence. As for actual clinical recurrence, actually having symptoms of disease, it was a relatively similar story. 13% of patients at some point developed clinical recurrence, which naturally increased the farther patients were followed. And again, the only risk factors associated with recurrence were patients that required a second-line biologic, those that required an examination under anesthesia for perianal disease, and in this case also patients that required an additional intestinal resection outside the ileocecal region. All of the other risk factors we looked at didn't have any impact on recurrence. As for how patients were managed once they did recur, everyone that was diagnosed with endoscopic recurrence had some sort of medical optimization. That varied pretty notably between patients, given the number of medications that are now available, but involved some sort of either being started or restarted on a biologic, having their dose changed, or being transitioned to a second-line biologic. As for those that actually developed symptoms, all of those also underwent medical optimization, which was successful for the vast majority of patients. There were actually only 4 patients, our entire cohort, that needed any sort of clinical intervention. 2 of those were successfully managed with an endoscopic balloon dilation for stricturing disease, and only 2 actually required a repeat resection and anastomosis. As for our conclusions, most notably, the endoscopic and clinical recurrence rates were lower than what has previously been reported in the literature, which likely simply reflects that these patients were drawn from the biologic era, and there's a lot more medications that are now available for patients. If the first-line medication doesn't work, they can be transitioned to a second line. Additionally, many of these patients were screened routinely post-operatively, regardless of any symptoms. And that allowed, in most cases, patients to be detected very early and have their medication optimized before their disease could subsequently progress. As for the risk factors for recurrence, they were unfortunately somewhat limited. The ones that we did note that were significant were probably more related to the overall disease severity of the Crohn's disease. Overall, our results do indicate that this very much is a medical condition, and that recurrence is best prevented by proper medical follow-up, proper surveillance, and having their medications optimized. If we as surgeons are ever asked to perform an additional resection and anastomosis, it certainly has to be a procedure of last resort after all of their medical options have been exhausted. So with that, I thank you, and I'm happy to answer any questions.
Thank you. Erin Teeple from Washington, D.C. That was a great analysis. I think you're right. We haven't done a really good deep dive since the era of biologics. Do you know how many postoperative patients were immediately replaced on a biologic or started on a biologic? We know that if we restart or start a biologic within 9 weeks of an operation, the length time to recurrence is much higher. Do you have that data about your population?
I don't have the exact weeks or months for what it was, but the vast majority that were on biologics preoperatively were continued postoperatively. And it seems like the 2 things that were most notable for preventing recurrence is not only continuing them on the medication, but also screening them very early for disease. For most of these patients, they actually got endoscopy, but some of the adult literature, they also recommend that for patients that are considered lower risk, you consider some combination of MRCP and stool markers as well, just to have some sort of rigorous screening analysis. At our institution, most patients get endoscopic screening, so that was really what we followed here.
Great, thank you.
Nice job. Have you looked at partnering with your adult colleagues to maybe get beyond 5 years? I think that's probably why you don't have many patients beyond that. That would be an interesting either retrospective or prospective study to look at when they age out of the pediatric systems.
Yeah, I think we haven't looked at that. I think that's a great suggestion. I think not only in our studies, but in most of the studies that we reviewed in the literature, there's pretty good follow-up at 1 year, 3 years, but it really does start to drop off after 5 years. And I think not only ensuring a good transition from the pediatric to adult care and making sure that the reemergence of early symptoms don't get missed during that time period would also be very important.
One last question about your endoscopic screening. When do you typically do screening at your institution?
It ends up varying a little bit. That we like to do it within a year. I've read that in the more in the adult literature, the patients that are deemed to be particularly high risk, it's recommended to do it often within 6 months, but usually within a year is what we've been focusing on.
Thank you.
Thank you. Okay, next, we'll have Dr. Suda from the Juntendo University School of Medicine.
Good afternoon, everyone, and thank you so much for a kind introduction, Chairperson. So nothing to disclose. So as everyone here knows, the heart-spring-associated enterocolitis, HAC, causes morbidity and possible mortality in heart-spring disease, HAC patients, even after pull-through surgery. Then its incidence can range from 2 to 33% for post-pull-through HAC, according to references, suggesting a more generalized cause involving the entire colon rather than just the ganglionic segment. The etiology of HAC likely include impaired GI mucosal immunity, immature viral defense, and microbiome gut dysbiosis. Tight junction protein, TJP, such as transmembrane, occludin, and claudin families are key players to regulate epithelial permeability and integrity. So we hypothesize whether tight junction protein's expression in normal ganglion link pull-through colon can be related to HAC. Claudin-4, a member of the TJP family, is a major indicator for gastrointestinal epithelial barrier. Interestingly, BLT2, namely leukotriene B4 receptor 2, which was originally identified as a low affinity receptor for leukotriene B4, enhances epithelial barrier function by promoting Claudin-4 transcription. Since there are several evidences that BLT2 agonists may improve epithelial barrier by upregulating Claudin-4, BLT2 and Claudin-4 axis can be a therapeutic target of epithelial integrity. Then, in this study, we investigated whether expression of intestinal TJP, including Claudin-4, and BLT2 in normal ganglion link HD colon for possible etiologic correlation with post-pull-through HAC. Resected bowel specimens were obtained during pull-through operation for HD from aganglionic rectum, HDA, and also normal ganglionic colon, HDN, for both short segment type RRS and also long segment type DT. Control colonic specimens were obtained from colostomy at ostomy closure in patients with ARA. Tissue specimens were used for immunohistochemistry for Claudin-4, and scraped epithelial were used for qPCR for several TJPs and BLT2, and also immunoblotting for Claudin-4. Data were compared among the groups as shown here. Then cases of HAC developing after pull-through were reviewed based on criteria of HAC defined by APSA score as shown here. Technical surgical issues and transitional zone pull-through were excluded. This slide shows a patient demographic. Then mean ages at the operation, sex, and the type of the aganglionic segment, and the incidence of pre- and post-operative HAC were summarized. From 14 cases with post-pull-through HAC history, we observed 18 episodes, including 5 of grade 1 and 13 of grade 2 in total. In qPCR, messenger RNA expression of several tight junction protein was significantly lower in both HD-A and N compared with controls, so indicating epithelial barrier in HD gut is abnormal. In immunoblotting, protein expression of Claudin-4 was significantly lower in HD-A and N compared with controls as well. Additionally, a significant decrease in BLT2 messenger RNA was identified in both HD-A and N compared with control. This slide shows typical imaging for the Claudin-4 immunohistochemistry. Then slight detection of Claudin-4 in HD compared with controls in the left panel can be seen. The findings from all cases were quantified by software and mean intensity were scored. From quantitative analysis of Claudin-4 in immunohistochemistry, mean intensity of Claudin-4 was significantly lower in both HD-A and N compared with control. And particularly, intensity of Claudin-4 in HD-N long segment in the right panel was lower compared with HD-A and N for the short segment type as well. When we compare according to the history of post-pull-through HAC, intensity of Claudin 4 was significantly lower in HDN from HAEC positive cases compared with negative cases. From all the 123 HD cases in our cohort study, post-pull through HAC was observed more frequently in long segment type than short segment type. In addition to our previous data, so it is suggested that low expression Claudin 4 can be a significant risk factor for post-pull through HAC in long segment type of the HD patients. So in conclusion, there will be a epithelial barrier dearrangement in HD normal ganglionic specimen, especially for long segment type, supported by decreased BAT2 resulting in lower Claudin 4 and post-pull through HAC positive cases that may have etiologic implications. Thank you so much.
Thank you. Do you have any thoughts for your next steps in terms of making this clinically applicable, either with treatments or whatnot?
Yeah, thank you for the question. So it must be the interest for the pediatric surgeons. So since we carry out the organoid culture derived from the HD patient epithelium, so we will test whether the BAT2 and the Claudin 4 can be targeted by the agonist to improve the barrier function in the in vitro first. Yeah, thank you.
So I have a question regarding the timing about when the specimens were taken. In other words, were patients having HAEC at the time that the biopsy specimens were taken? And the reason I ask is that it may affect the results. In other words, this may be a secondary effect or a primary effect of the HAEC.
Okay, so if I'm not wrong, my answer can be, so we obtained the specimen at the pull-through surgery from the HD patient.
It was always at the original surgery.
Exactly, yeah.
So, excellent. All right, thank you.
Hi, Dr. Sida. Congratulations for the presentation. Always very nice. Paolo De Coppi from London. Is Claudin 4 expression conditioned by any immunological clues in the sense that can immunology in the bowel change the expression of Claudin 4 or not?
Yeah, thank you for the question, and it's critically good point. Then, yes, this time we only focus on the epithelial tight junction, but I think this is kind of secondary effect due to the immunological abnormality or even a dysbiosis in the gut. Then, in my speculation, dysbiosis comes first. Then, secondly, it affects the epithelial barrier and the immunologic reaction. So, I think multifactorial.
Thank you.
Thank you.
Thank you.
Thank you.
Next, we have Dr. Melkonian from Children's Hospital of Colorado.
All right. Thank you for giving me the podium to talk about an important topic today. So we have nothing to disclose. So why we did this research. So there's significant health impacts and social costs to poorly controlled constipation and fecal incontinence. I've been able to witness how transformative a successful bowel management can be for our patients and their families. And since the majority of the medications that we use are over the counter, the question arose, what economic impact does this have on our patients and their families? And taking this a little further, if we could alleviate these financial burdens, could we increase medical adherence, overall patient quality of life, and then decrease costs to our families as well as the hospital system as a whole? So chronic constipation and fecal incontinence are devastating problems for these kids with colorectal disease of childhood. Finding the proper bowel regimen allows them to be socially continent and therefore improves the quality of life for both them and their families. They often require laxatives and enemas for their management, and this may be lifelong treatment. So these products are sold over the counter, and insurance companies do not include them in their formularies. As such, the financial impact of these medications should not be ignored. So in this study, we reviewed the cost of the bowel management regimen medications that we prescribe, looked at the economic impact on the families that we treat, and look at this juxtaposed against their median annual income. We performed a retrospective review between January 2016 and September 2023, where we looked at patients undergoing bowel management through our institution. We looked at the range of laxative dosage and enemas by doing a chart review, looked at census data for their zip codes to get their median annual income, and included patients who underwent formal bowel management week and were prescribed laxatives and enemas. We only included patients who were on enemas containing saline and glycerin, and only used patients that were on laxatives alone. So a Google search was conducted, and we wanted to identify the cost of these bowel regimen medications. So we looked at 6 different major commercial distributors, well-known names, and we also looked at the diaper costs at the same time. And we compared this to the cost at our hospital pharmacy as well to see what we were selling these drugs for. Laxatives, we only looked at senna-based products with no other ingredients involved, and enemas, we only looked at glycerin because the normal saline that we utilized, we had instructions for patients to make their own normal saline at home, so this was negligible. On review, 430 patients met inclusion criteria. 1/3 of them were on laxatives and 2/3 were on enemas or antegrade flushes. And there was significant variation on the cost of medications based on which store or distributor these were purchased from. In this table, you could see from the least expensive store, an X-Lax 15 milligrams, 24 count would be $5. And at the most expensive store, for the same exact product, it could be $11.18. For glycerin, you can see down lower, we were making a killing at our hospital pharmacy with $17.79 for our glycerin. And for the least expensive store, it was $1.45. So if a patient is on 60 milligrams of X-Lax daily, and they bought it from the cheapest store, they could pay $260, where at the most expensive store, they could pay $686. This is a difference in cost of over $432 a year. And in glycerin, it's even more significant, where they could buy it for $87 versus almost $1,100 annually. And the difference in cost here is over $1,000. So we created a heat map looking at the median annual income of our patients. The number of patients is listed here in each state that we've treated in over 41 states total. And then to the right, you can see their income quartiles. And 60% of our patients fell in the first 2 quartiles, where they made less than $89,000 a year. And 48 of those patients actually make less than $55,000 a year based on their zip code. So putting this into context, patients on laxatives could be paying anywhere between $15 to almost $3,000 annually, depending on their dose of their bowel regimen. For a mean dose of 60 milligrams, this is about $530 a year. For glycerin, anywhere from $30 to $4,300 a year. And for a mean dose of 30 milliliters, which is what our patients were on, is about $591 per year. So if patients are making low annual income and they have pretty significantly high medical regimens, they could be paying up to 10% of their annual income towards these medical regimens for their kids. Looking further into diaper costs, which we broke down less than 100 pounds and over 100 pounds, and this was taking into account patients after potty training age who should not need diapers anymore. We saw also significant costs, and you could surmise from this that if you had a good bowel management regimen, and especially in the older patients, you could also have a lot of cost savings by addressing this issue. So the takeaway points here is bowel regimen costs really financially burden the families that we treat. Cost savings can be achieved just by educating them on where the cheapest places are to buy these medications. And also we can talk to them about other things like GoodRx, which are programs that can help them get these medications for cheaper. And then advocacy for insurance coverage of these essential chronic medications for these chronic diseases is really important too, both for the families and for our healthcare system as a whole. The limitations to the study was a retrospective review, and also the income data was not specific to our patients, as it was using their zip code, which might not adequately represent what they actually make per year. I want to thank my colleagues and my mentors for making this project possible, and I'm happy to take any questions.
Thank you for this study. I think, it really goes to show in terms of the social determinants of health. This is a really, clear picture of what our parents and patients go through. I'm interested to know, you found the cost based on a Google search, but do you have the actual stores or sources that your patients actually use?
I do.
And
yeah.
on that, while we continue to lobby for insurance coverage for these medications, is there a list that we can share amongst ourselves to help our patients?
Yeah, thanks for that question. So I don't know the exact stores that each patient used specifically, but I have the stores listed as to where I got all of this data from. And I do have a massive list of where you can buy all these things from. I felt weird putting it on the stand because I didn't want to act like a market, trying to, unless they want to sponsor me, in which case I will put it up there. But if you email me, I will send it to you and you can use it for your families and patients.
Congratulations, very well presented and an important topic. One, two things. One, as now an AARP member, I know what it costs to find medications, and so I think it's going to be regionally dependent, and what's good in Denver might not be good in New York City, et cetera. I think, and I'm going constantly changing pharmacies just to play the game of where I could get it cheaper. But do you have a process in place at your institution where you talk to the families, every family that comes through, to really implement this in a way? Because what I'm learning at APSA is, yes, we're defining that there are issues with payer status and access to care and access to treatment, but how do we implement this in a way that works, other than saying, hey, there are cheaper stores, but Walgreens, or I shouldn't have said that, strike that. Some store in Phoenix might not be the same price as some store in Cincinnati.
For sure. Yeah, no, it's a great question. Thank you for it. It's, I think this is, ever since we saw this, we've started telling patients where to buy things from, because it really opened our eyes as to where they can get it the cheapest. It would be different regionally, but I think one thing that can come out of this is we can come up with a way that maybe we can have a quick way to send this information to an insurance company per each patient so that we can argue for each patient, hey, cover this. I don't know if it'll work, but it might be the next step to see if we can make things work. So.
Thank you.
Thank you.
Next, we have Dr. Ncisco from Mayo Clinic and Cincinnati Children's.
Thank you for the opportunity to present. Wait for my slides. We have no disclosures to report. So why did we do this research? Well, we know that Hirschsprung-associated enterocolitis is still a source of morbidity amongst Hirschsprung patients, as we heard earlier. And we're looking for ways to treat and to prevent it. There's literature supporting it as a rectal Botox injections as a treatment, and here we're presenting data to support it as a preventive strategy. So like I just said, Hirschsprung-associated enterocolitis continues to be a common cause of morbidity and even occasional mortality in Hirschsprung patients. The literature supports some literature supports rectal Botox injections as a treatment strategy, including decreased episodes of enterocolitis and increased interval between enterocolitis episodes, but there is less data about its use as a preventive strategy. Here, we evaluated our institution's cohort of patients with Hirschsprung disease, first to determine the incidence and epidemiology of Hirschsprung-associated enterocolitis at our institution, and second, the main point here, to assess the efficacy of Botox on decreasing the incidence of Hirschsprung-associated enterocolitis. So we started with a retrospective review of patients seen at our institution between 2005 and 2019. And these patients may have come from elsewhere, but like I said, we're seeing our institution had previously undergone a pull-through procedure or an ostomy takedown after initial diversion. Then we have a prospective study since 2020 looking at patients operated on at our institution, and at the time of pull-through or ostomy takedown, they undergo rectal Botox injections. We chose that time point in the thought that maybe preventing the bacterial overgrowth may mitigate any future enterocolitis episodes. And for all of the patients, we took a look at the enterocolitis episodes post-operatively, and for the prospective patients, we also looked at their 30-day complications. So 233 patients were reviewed, 219 of them were analyzed, 39 of the patients received upfront Botox injections, and 180 of them did not. And over 50% of them underwent primary pull-through. Looking at the postoperative incidence of enterocolitis, nearly half of all patients had at least one postoperative enterocolitis episode. Nearly a third of patients had multiple enterocolitis episodes. And we found that fewer patients who received the upfront Botox injections had any or multiple enterocolitis episodes. One of the limitations of our study is that as a referral center, we had a lot of patients coming from other hospitals, and we therefore didn't have all of the documentation available to review. And so we did a subset analysis of the patients who had surgery at our institution, and we saw similar findings here too. And that fewer patients, again, who received the upfront Botox injections had any or multiple enterocolitis episodes postoperatively. We then took a look at the timing of the postoperative enterocolitis episodes, whether it occurred within a month after surgery, within 2 months after surgery, within 3 months after surgery, and so on. And here we found that fewer patients with upfront Botox had enterocolitis episodes within the first 30 days after surgery. And here's a graphical representation of that finding, again, showing the significant difference at within a month after surgery between the patients who underwent upfront Botox injections and the green line compared to the patients who did not undergo upfront Botox injections. As you can see, the lines kind of level out after that. Looking at the complications, again, in the patients who followed prospectively, we saw a high incidence of diaper rashes. Over half of patients had a diaper rash. We've instituted measures to try to mitigate the diaper rashes, including for patients with ostomies, having stool exposure to their skin to try to desensitize the skin, and postoperatively, after pull-through and ostomy takedown, aggressive topical treatments to try to prevent diaper rash. So overall, upfront Botox injections we found reduced the incidence of postoperative Hirschsprung-associated enterocolitis, particularly within the first 30 days after surgery. Botox injections may be associated with a high incidence of postoperative diaper rash. Thank you, and I'm happy to take any questions.
Andrea Bishop, Children's Hospital, Colorado. Congratulations. I think I was thinking about asking for diaper rash, but you already answered my question. We always joke you can choose between enterocolitis or fecal incontinence, right? So in this case, you are avoiding enterocolitis, but you're giving them fecal incontinence. The question is, how often did you have to do Botox injection and for how long? Because we know enterocolitis happen during the first years of life, and then we don't see when they are teenagers, when they are older.
That's a good question. A lot of the patients that we looked at did receive subsequent Botox injections. I don't have the exact numbers right now as to how many of them or how many future Botox injections they did receive, but a lot of the patients who did have episodes of enterocolitis underwent future injections of Botox, and I can certainly look further into that. That's a good question.
Rodrigo Romao from Sick Kids in Toronto. Thank you. That was interesting. I'm a fan of the upfront Botox injection. I've been doing it for a while. I saw that in my question is similar to the previous question in the sense that I see that there's a separation again in the curve. I know the numbers are small, but in the last graph that you showed after a year, it seems like they separate again. So is there a plan to maybe study, because we know Botox wears off, so is there a plan to maybe study like going through a program of injections over a certain period of time, or is this more like surgeon dependent at this point?
Yeah, I think that'd be a good idea to look into. Like I said, we have the numbers for which patients had future Botox injections. I think part of the reason it spreads again at the end is that some of the patients retrospectively, we just have a lot more years of data for them versus the patients that we recently operated on. We don't have as many years of data. So I think that's part of the reason, but certainly looking more into that would be a good idea.
Thank you.
Next, we have Dr. Worley from West Virginia University.
Thank you very much for the opportunity to present. Up to this date, there are no reports on the histopathological findings within the resected rectus sigmoid of patients suffering of chronic idiopathic constipation with megarectus sigmoid so far. We wanted to shed light on the histopathological findings in those patients suffering of severe chronic idiopathic constipation and to help better understanding the disease process. So far, 3 surgical approaches have been described. The sigmoidectomy, where the sigmoid is resected, as shown here in red, and the rectal pouch is left behind. the rectosigmoidectomy, where the sigmoid and rectum are resected. The proximal rectosigmoidectomy, where the sigmoid and the part of the rectum are resected, a small rectal pouch of 5 centimeters is preserved. We performed a retrospective case review of patients who underwent a proximal rectosigmoidectomy at the Children's Hospital in Pittsburgh from July 2017 till May 2018. The resected specimens were sectioned proximally and distally, as well as a longitudinal section was obtained and analyzed for thickness of the musculature, so of the outer and the inner musculature, the lamina propria thickness, and nerve fiber diameter. Those were then compared to age-matched controls, which were obtained through a search of the pathology archives of autopsy and surgical cases of age-matched and gender-like controls. Those suffering of constipation or having a history of neuromuscular or GI issues were excluded. Statistical analysis was performed and the study was approved by the IRB. Comparing cases to controls, as you can see here, they were significantly thicker in all layers, proximally as well as distally. Or in other words, there was significant muscular hypertrophy, hypertrophic nerve fibers, and thickening of the lamina propria found proximally as well as distally. The thickening of the lamina propria was mainly caused by an increase of connective tissue, as shown here with the Masson trichome stain, staining connective tissues blue. We then compared within the patient population proximal versus distal, and you can see here there was statistically significant thickening of the outer musculature, nerve thickness, and lamina propria thickness distally compared to proximally. To our knowledge, this is the first report of a series of histopathological findings of patients suffering of chronic idiopathic constipation undergoing a rectosigmoidectomy. We found significant muscular hypertrophy, thickened nerve fibers, and fibrosis of the lamina propria, more so pronounced within the distal portion, the rectum. These leads to the concern that the origin of the disease process is actually found within the rectum. Further studies are needed to assess the extent and the reversibility of the disease process. Thank you.
Nice presentation. Did you look at ganglion cells at all, see if there's any loss?
Yes.
And what did you find?
So we found ganglion cells within all specimens. I mean, there were no Hirschsprung disease patients. We found them all throughout the specimens, and number-wise, they were normal compared to the controls. So.
Hi, that was a great presentation. Christina from DC. Just wondering how you selected, or did you go through the reason for the rectosigmoid resection on those patients? Like, was the motility in that segment or any workup before that?
Okay. So motility-wise, we did not study those patients. We presented the patient population 2019, and it was published. There were 13 patients, age range from 3 to 18, all had a long history of chronic constipation. They all failed medical management, laxatives, and enemas, and therefore were presumed to surgery.
Thanks.
Thank you. And staying up here is also Dr. Worley to present another study.
Okay, thank you very much again. There are only a few long-term studies about the urological outcomes in patients, female patients, born with anorectal malformation and Hirschsprung disease. We wanted to assess and compare self-reported urinary outcomes in adult females born with congenital colorectal conditions. We're happy to present those results today. female-born patients with anorectal malformation or Hirschsprung disease with an age between 18 to 80 years of our adult colorectal registry were asked to participate in our survey. Those who answered the questionnaires about the urinary functioning from November 2021 till August 2022 were included. We used the validated lower urinary tract symptom questionnaire, and additionally, the rates of urinary incontinence were compared to the reference population of US women between 30 and 39 years of age. Statistical analysis was performed and an IRB was obtained. 64 born female patients, with 2 of them identified as non-binary, were answering the questionnaires, which led to a response rate of 76%. Age ranged from 22 to 80 years, with a median age of 31.6 years. The majority had a diagnosis of cloaca, followed by other types of anorectal malformation, complex malformation, and Hirschsprung disease. 86% had a history of urinary tract infection. 66% reported that their last UTI was less than a year ago. All patients with a cloaca, except one, had a history of UTIs. 27% of patients underwent bladder reconstruction and/or augmentation with the creation of a channel. It's important to note that the validated urinary tract symptom questionnaire has its weakness for this population. 11% reported that they had chronic kidney disease stage 3 or higher. 6 had a diagnosis of cloaca, 1 a cloacal exstrophy. 5 of them were born with a single kidney and a sacral ratio less than 0.4. 3 required a kidney transplantation. All patients were followed by nephrology since early life. We then looked at the rates of urinary incontinence. Anorectal malformation patients reported a rate of urinary incontinence of 22%, which was non-significant when compared to US females with an age between 30 and 39 years. Cloaca patients had a rate of urinary incontinence of 47%, complex malformation 50%, and Hirschsprung disease 0%. It only reached statistical significance for the patients with a cloaca. For the subgroups of complex malformation and Hirschsprung disease, you see that the group numbers are little and low. We further then looked into the urinary tract symptom questionnaire for anorectal malformation and cloaca patients. We were surprised to find the rates of the symptoms by the group of anorectal malformation that were statistically significant for the question, do you strain to start or continue urination, the rate of urinary urge incontinence, as well as urinary leakage without physical activity or need to urinate. Our hypothesis for those statistically significant rates is that the urinary tract symptom questionnaire has a reference population that is younger than our patient population, with an age range of 18 to 26. We do know that urinary incontinence rates increase over age. We then looked at the cloaca subpopulation, and as you can see, all symptoms were significant except for the frequency, how often they urinate per day. 15% of the patients with a cloaca reported social problems due to urinary incontinence. Or in other words, 85% of patients with a cloaca did not report any social problems, even though 47% of the patients with a cloaca suffered of urinary incontinence. In conclusion, this study emphasizes the need for a multidisciplinary team that includes urology and nephrology following patients with anorectal malformation long-term, especially within the subgroup of cloaca. It also highlights the need for better validated questionnaire for patients who underwent bladder reconstruction and/or augmentation and catheterized through a channel. Thank you.
Thank you so much for that. It looks like you have a nice wide age range there. Did you happen to parse it out of decade of life? I'd be curious to know when these symptoms are most problematic for these people.
So I do not have them in my head, but what we did, we studied the patients. As you can see, we had a patient that was 80 years of age. She actually did great. We did run the analysis twice, once with patients up to an age of 40, and once we excluded the patients who were older than 40 years of age. And the results did not change, so they stayed the same.
You think that women or people who have high sex hormones, not postmenopausal women, have the same amount of symptomaticity as postmenopausal women? Is that what I just heard you say?
Correct. Yes.
Oh, that's very
yes, and that urinary incontinence might not, it changes with age, but those having already issues start early in life due to their anorectal malformation.
That's very interesting. Thank you.
So I have two questions. You mentioned there were 6 patients with a complex malformation, if you could tell us what those were. And then the other question, kind of similar to what Dr. Tipo was referring to, are you able to parse out, did the urinary continence change relative to childbirth? Not just age, but actually having a vaginal birth.
Sorry, repeat the second question.
Are you able to look at your data to see if urinary continence scores, regardless of ARM or cloaca or otherwise, did those change relative to childbirth?
Yes, so we looked at those data and have reported them or published them already. All of these patients that had or gave birth, they did not give birth spontaneously vaginally. They all had a C-section. So we did not assess if urinary functioning deteriorated after birth because it was just a cross-sectional study at this point. Yeah. For the complex malformations, those were patients with cloacal exstrophy. One patient had a duplication and a very bizarre anatomy. Okay.
Thank you.
Thank you.
And last but not least, we have Dr. Padwarden from Rady Children's Hospital.
Good afternoon. My name is Utsav Patwardhan, and I'm a research resident at Rady Children's Hospital, San Diego. Thank you for the privilege of the podium today. We have no relevant disclosures. Colonic atresia is associated with the low but poorly defined incidence of Hirschsprung disease. In some cases, this may be the result of a vascular insult, which disrupts distal propagation of ganglion cells. Alternatively, distal aganglionosis could lead to proximal distension, twisting, and atresia. Due to concerns about constructing an anastomosis proximal to aganglionic bowel or dysmotility due to distension, some surgeons elect to perform diversion with a staged anastomosis. Given these knowledge gaps, we sought to better define the incidence of concurrent Hirschsprung to evaluate contemporary practice. We used FIS to identify patients who underwent operative repair of colonic atresia between 2013 and 2022. We excluded initial operations beyond 14 days of life and patients with concurrent small bowel atresia, gastroschisis, or anorectal malformations. Procedure codes were assessed to determine the nature and timing of index operations and the anatomy of any stomas that were constructed. Outcomes included surgical complications, duration of TPN, time to ostomy closure, and unplanned operations. We defined an unplanned operation as any abdominal operation that occurred after the index anastomosis, or for index ostomy patients, any operation besides the ostomy takedown. 69% of our patients underwent intestinal diversion at their index operation. Patients who underwent diversion or primary anastomosis did not differ based on sex, race, gestational age, birth weight, or age at operation. Among patients who were diverted at their first operation, 2/3 had a colostomy. When a primary anastomosis was used, a colic anastomosis was done in 73%. Surprisingly, patients managed with the primary anastomosis were no more likely to have had a rectal biopsy prior to or at the time of operation. It is possible that some of these patients had frozen section assessments at the time of the operation, but this would not be apparent on FIS. Although 2/3 of diverted patients had a colostomy, a majority were ultimately reconstructed with an ileocolic anastomosis, in contrast to the primary anastomosis group in whom the colon was mostly preserved. Finally, stomas were closed at a median of 92 days. There was no significant difference in subsequent unplanned operation between the groups. However, the duration of TPN was greater after a primary anastomosis. The incidence of surgical complications was similar, and there were no differences in length of stay between both groups. Hirschsprung disease was ultimately diagnosed in 9.5% of our cases. In only one of these cases was there a documented rectal biopsy prior to the index operation. 3 others were diagnosed on a rectal biopsy done within 12 days, and it's likely in the remainder Hirschsprung was diagnosed based upon frozen or permanent section, but again, this data is not available. 1 patient was diagnosed with Hirschsprung after being immediately reconstructed and had to be taken back for an ileostomy at 92 days. In summary, 9.5% of patients with colonic atresia had concurrent Hirschsprung. Almost 70% underwent diversion, most of which were colostomies. However, in half of these cases, the colon was not ultimately preserved and an ileocolic anastomosis was constructed. Distal aganglionosis was missed in only 1 patient. Although rectal biopsies were documented less than 40% of the time, many patients presumably had intraoperative biopsies. To conclude, we found the proximal colon is rarely preserved in colonic atresia, even after diversion. Aganglionosis in colonic atresia can be reliably detected with rectal biopsy or intraoperative assessment. If biopsies are attained, especially with frozen section, a primary anastomosis can be safe and effective. Fortunately, even if a pathologist is not available, the rate of concurrent Hirschsprung is less than 1 in 10. As with any studies using an administrative database, FIS does not provide clear information about clinical factors like hemodynamics, the length of the atresia, or the extent of proximal colonic dilation. Regardless, it provides valuable data about a fairly rare clinical entity. Thank you very much for your time. I'd like to acknowledge the support of my mentor, Dr. Gollin.
Hey, Andrew Zigman, Portland, Oregon. Thanks for putting that series together. That's a pretty rare bird. It's nice to be able to get some numbers for that association. You know, up to this point, what we've known about this through smaller series is that the risk of Hirschsprung disease is higher when there's a left colon atresia, based on smaller series. Did you, going through your data, notice any differences in site of colon atresia in relationship to Hirschsprung disease?
So the way the diagnosis codes are made, it's very difficult to figure out the location of the atresia. Just one of the inherent limitations of pulling the FIS codes. I'd have to look back and see, but I don't think we were really able to localize. We could get a sense of it based on the surgery that was done, so whether they did a left transverse, so basically what part of the colon they removed. But in some cases, if they did a long segment, we don't really know which part was it. They did a part of the transverse because of dilation, or was it because it was atretic? So it's a little hard to tell. But it's a very good.
I can appreciate that. It could be difficult to parse out from this type of database data. Okay, thank you.
Thank you. So that concludes our excellent scientific session. We continue back at the main room for a variations in care session. I think we have about 5 more minutes, so please make your way back to the main room as quickly as possible. Thank you.
And if you're a scorer for the awards, please turn them in within the next 30 minutes so that I can begin tallying. Thank you.